guests are Dr. Bill Nokia and Dr. Nombuso Mathe, both of whom are ophthalmologists. And I'm going to say good evening to Dr. Bill Nokia, and thank you for joining me on the program this evening.
Thank you, and thank you for inviting me. Nice to meet you, Faisal.
Likewise, Dr. Nokia and Dr. Nombuso Mathe. Thank you very much for having joined me on the program this evening.
Thank you for the invitation. It's a pleasure to be here.
You're most welcome. And I know you have very busy schedules, so I know it's a special sacrifice you made to join me on the show this evening. Just to introduce our guest, Dr. Nokia has been an ophthalmologist in private practice since 1988 in Durban, South Africa. He is primarily a general ophthalmologist with an emphasis on cataract and glaucoma surgery, corneal cross-linking, medical management of macular degeneration and diabetes, as well as refractive surgery. He is and has been an active member of several local ophthalmic societies, including the Ophthalmological Society of South Africa, the South African Glaucoma Society, the South African Society of Cataract and Refractive Surgery, and the South African Retinal Society. He has served on several of the executive and local committees over the years. He organized the local OSSA branch for 10 years and has been the convener of four major ophthalmology congresses and has been on the organizing committee of several others, including 6 SASCRS and 15 glaucoma congresses. Dr. Nokia is the immediate past president of the South African Glaucoma Society. The aim of the society is to increase understanding and surgical skills in South African ophthalmic surgeons. Outside of work, his family is his main interest. Planning and going on holidays with them is a big fun part. And Dr. Nombuso Mathe is an ophthalmologist and the chief specialist and academic head of department of the discipline of ophthalmology at the University of KwaZulu-Natal and the Department of Health KZN. She trained as an adult and pediatric glaucoma specialist at Moorfields Eye Hospital in the United Kingdom. She is the vice president of the South African Glaucoma Society, then Ophthalmology South Africa, and is on the Global Advisory Council for Women Leaders in Eye Health. She is also voluntary faculty and surgical coach for Orbis International, a globally recognized non-profit organization. Dr. Mathe's passions lie in clinical governance in eye care, surgical training, as well as the management of pediatric and adult glaucoma patients. Uh, Dr. Nokia, let's just start with yourself. Our topic for discussion is glaucoma. What is glaucoma?
In simple terms, for the lay people, glaucoma is where the pressure in the eye is too high. So just like you have a tire pressure in a motor car or blood pressure in the arm, the eye has a pressure. But if that pressure is too high, it causes damage to the optic nerve. And this damage to the optic nerve leads to loss of these nerve fibers and eventual slow loss of vision. Now, that's a very simplistic overview because when you get academics together, it gets far more complicated than that. But in a nutshell, for the lay public, that's a nice, simple overview. And the big danger of glaucoma is that your eye is white, there is no pain, and you don't even know that you're losing vision. And that's why it's such a bad condition.
Hmm. And Dr. Mathe, who is most at risk to develop glaucoma?
So, so as Dr. Nukia has mentioned, patients that have high pressures in the eyes tend to be at the highest risk. And then, of course, it is a disease that can pass down families, so it's highly heritable. So, if you have a family member, first degree, so a parent, a sibling who's diagnosed with glaucoma, they'd be at high risk. And then there's certain conditions. Such as patients who are short-sighted or have myopia, they can be at risk of developing glaucoma. Patients that have had an injury to the eye, patients that may also have other systemic diseases, so other illnesses such as diabetes, hypertension. There's some associated risks to developing glaucoma. And then patients who are using certain types of medications. So if you're somebody that is using what we call corticosteroids or cortisone or prednisone, this would be a drug in different forms. It could be a tablet, it could be a spray that you use in the nose, it could be an asthma pump, it could be a cream that you use for a rash. This is a group of drugs that also increases the risk of developing glaucoma. And it's also, we talk about people adults over 40, but we do see a lot of patients at a younger age that develop glaucoma. It is typically an older people's disease, but you do also have children that may develop glaucoma as well. So there are a
Mhm.
number of different possibilities in terms of who might be at risk.
Thank you for that, Dr.
And,
Martin.
and
Now,
Faisal,
yes,
may
sir.
I come in here?
Yes, please.
One of the big things that is a real problem is that for some reason, people, indigenous people from Africa, have a much higher incidence of glaucoma worldwide compared to other groups on the other continents. And I don't know, maybe Nombuso can tell us if there's latest research because she's closer to it, but it's more than double the incidence in other places like in Europe, Japan, North America. It's much more common, and it starts at an earlier age. Nombusa, you work in the clinics. That's your experience, isn't it?
100%. We're not seeing the typical over 40 or over 60 age group. These are young patients in their 30s, very aggressive disease, so disease that's really advanced even by the time that they come into the hospital. Often they've lost vision in one eye, and it's just a rapid loss of vision. The pressures tend to also be very high, and there's a number of reasons we think that there's this sort of a higher disparity in terms of the racial grouping of people. Part of it is also maybe related to access to care, access to screening, access to information, and often, in the more peripheral areas, you don't have as many ophthalmologists, if you have any at all. So there are a number of different reasons, but there's obviously a lot more work that needs to be done in terms of understanding genetically what might be linked to that, and there is a lot of work that is going on in that. There have been some risk factor genes that have been identified that are helping sort of explain why there may be that disparity between your Black or African descendant patient and other groupings in the world, including the Hispanics as well. So there's a number of specific groupings of people that are at much higher risk.
Mhm. And are there any reasons for this, or has any research been done as to what's causing this? Why are they at a greater risk?
So yes, there's the socio economic aspects of less access, less information, less access to care, less access to screening, less access to ophthalmologists. But there have been some risk factor genes that have been identified as well. So risk factor meaning it's not an exact genetic mutation that leads to the disease, but it's a mutation that has been noted to increase the risk of eventually developing the disease. And this has been one of the things that has been found in terms of being higher for your African or African descendant patient. There's probably a lot more to it that we don't, that most people and many scientists are not yet fully understanding of the disease.
And
And
Faisal,
yes, sir.
there's another issue in that just lack of awareness and understanding of the disease. So even in the West, Hippocrates seemed to have discussed or described some sort of glaucoma. But in Europe, glaucoma was not separated from cataract surgery clearly by doctors until about 17 or 1800. And again, Nombusa can enlighten us here. But certainly in other countries that I've worked in many local African languages, there's almost no different word for glaucoma and cataract. It's a
Mhm.
concept that's not really people are even aware of. And you speak to the average layperson, they're not aware that there is this disease. And of course, Add to the woes of Africa malaria, diabetes, HIV, and all our other issues. It gets swamped by all those other important things, and so you will have young people, as Nombuso says, presenting at the clinic in their 40s, blind in one eye already, and 80-90% loss of vision in the other eye. So it's like an unknown, just people are just not aware of it.
Mhm. I haven't given out the studio numbers yet, but a question has come through, and the listener says that a great topic. What is the difference between a cataract and glaucoma? I can.
So maybe I can
Yeah.
try and enlighten. Yes. So as Dr. Nukia has tried to explain that with glaucoma, the pressure in the eye tends to be high. I often like to use the example of if each eye has a nerve which is like a cable that transmits this information that we would appreciate as sight, and with the impact of the pressure, you then get a damaging of that nerve, and the nerve in the eye is a connection between the brain and the eye. So damage to that cable will cause permanent loss of vision, whereas a cataract is more a wear and tear disease. So it's a change that happens in the part of the eye that we call the lens. So if you imagine a pair of spectacles, if you're holding them in front of you, there's a lens, glass lens in there. There's a natural lens that we everybody has in the eye, and with time, with age, as we say, wear and tear, that lens starts to change from being a structure that's very clear to being something that's a little bit cloudy, and so that can cause a change in the vision. But cataract does never causes permanent vision loss because we have technology and we're able to intervene in a way that we can reverse the loss of vision that may happen from the cataract. Whereas with glaucoma, we don't have the technology as yet to reverse the loss of vision that happens from it.
Mm.
Thank you so much, Dr.
And
Matthew.
then and then adding to that, Faisal,
Mhm.
if the cataract surgery diagnosis is delayed, as Nombosa says, we have technology to go in there and take out the cataract, and we will get restoration, 100% restoration of vision.
Mhm.
But with glaucoma, a delay in diagnosis means further damage to that cable, to that telephone line that she was talking between the eye and the brain. And that is an ongoing damage. So the timing in glaucoma is critical. And when it's painless and the eye is white and you don't have any pain, and remember, it's the in glaucoma, the vision loss starts from the outside and it moves inwards. And it's
Mhm.
only when it gets to the middle that the patient realizes that there's a problem. By the time the patient realizes there's a problem, it's too late.
And
If I can just add to
yeah,
that
sure.
as well, each eye, if you close one eye and you look out to the other, what you
Yes.
see out of that eye will be a little bit different to what you see from the other eye. So, with the change that happens in glaucoma, it's not always at the same place in either eye. So, what the brain doesn't like to get confused. It merges these two different images to make one. And so, where there's some change or loss of vision in one eye, the brain can try and plug that information from the other eye. And so that's
Mm.
why most people will not really see that they can't see until it really bad, as Dr. Nakia has pointed out. And partly that's often what happens when patients come in late, that if they're not closing one eye and checking, you won't really know that there's a difference in the way that you see between the two eyes if you're someone suffering from glaucoma. And a lot of the diagnoses as well are incidental. So patients that go in maybe for their routine spectacles test, and if they happen to mention to the optometrist to say, the image, I'm not seeing as clearly with this side, looks like it's half. That could be a sign of something. But often patients don't think that's information to bring forward. So any change that may be different in either eye, if you're able to isolate either eye, that might point towards something. It's not something to ignore.
Just to remind our listeners that you are listening to Medical Files brought to you by the Islamic Medical Association of South Africa. Our topic for discussion is glaucoma, and our special guests this evening are Dr. Bill Noke and Dr. Nambuso Mathe. This is an interactive program, so if you have any questions you may on glaucoma, you may forward them to us via WhatsApp on 060 904 1056. Now, just to remind you as well that doctors and guests on the Medical Files program will help you with any medical problems that you pose by giving you advice on air. However, they do not have your full medical history and have not examined you. Please verify the advice given to you on air with your regular doctor who knows your medical history, your allergies, etc. Neither the doctors nor the relevant radio station nor the Islamic Medical Association of South Africa will take any responsibility for any adverse reaction caused by the advice given on Medical Files. Just to repeat the number, it's 060-904-1056. Now, Dr. Nokia, uh, what are the symptoms of this disease? What does one look for? How will one know that one is prone to this disease?
How do you know if you're prone to the disease? Well,
Or rather, what are the symptoms rather?
yeah, well, the symptoms. Nombusa has just discussed them. Dr. Mate has just discussed them. The majority of patients, there's none, absolutely none. They're not even aware they've got it. And the eye has this, the brain has this compensation mechanism. And so in the majority of people that we see, it's discovered by accident. They happen to cover one eye and suddenly notice that the other eye is very badly damaged and can see very little. Or in a lot of the cases, they go to the optometrist for glasses, because most people at the age around 40, 45 need reading glasses. And in South Africa, we're very, very blessed because we have superb optometrists. By and large, in South Africa, our optometric association have trained up really good optometrists, and they are usually the people that the general public see. The people who sell glasses in the shopping malls and in the shops, those are usually the contact, because the number of ophthalmologists, only about 300 ophthalmologists in the whole country, and they're quite busy, particularly are people like Dr. Mata, who is drowning in far too much work. So they will go in and see one of these optometrists who will do an examination, and they will often check the pressure and examine that nerve at the back of the eye, the cable, the telephone line that Dr. Mate discussed between the eye and the brain. And looking at those two features, the cupped disc and the raised pressure, will be alerted to it, and then draw to the patient's attention. So the bottom line is that the majority of people who've got glaucoma don't know they've got it. And so that's why we think programs like this are fantastic, because it raises awareness. So if you have any relative, a mother, a father, a brother, a cousin, an uncle who says he's got glaucoma, there's a possibility that your family, someone in your family, will have it. And you should all go and be tested.
Okay,
If I may
we're gonna.
add to that,
Yes, sure, you may.
So there are some patients may experience headaches. That is one of the side effects, as not side effects, symptoms. As Dr. Nikia has mentioned, that majority of patients may have nothing. Some patients may experience headaches. In fact, a third of patients with migraines or diagnosed with migraines are actually a misdiagnosis for a type of glaucoma. Some patients may have fluctuating vision. So I often ask my patients what their vision is like early in the morning. And some patients may experience a little bit of clouding very early in the morning, and the vision then clears up as the day progresses. Some patients may have a little bit of discomfort and pain in the eyes or light sensitivity that usually points towards the pressure being extremely high in the eyes. Patients may experience discomfort, especially sitting in a dark room. So if you're sitting in a dark room and you've got the side lamp on, they may experience some discomfort in the eyes. Some patients may complain of glare or seeing rainbows in certain light conditions. And patients with sort of more advanced, established or more advanced glaucoma may have a preference for They may feel as though their vision is better if it's a little bit sort of duller. The weather is duller, or it's
Hmm.
more cloudy. They may feel more comfortable, and when it's very bright and sunny, they may struggle a little bit. So these are some of the things that may impact, and it's not necessarily at the start of the disease, the middle of the disease. It can be at any point, and some of those might point towards a disease that's already established as well.
Thank you for that, Dr. Martin. We need to take an ad break. We'll continue on the other side of this. To stay with us. You're listening to Medical Files, brought to you by the Medical Association, Islamic Medical Association of South Africa, and our topic for discussion is glaucoma, and our special guests this evening are Dr. Bill Nokia and Dr. Mambusa Mate, both specialist ophthalmologists. And if this is an interactive program, if you have any questions, you may forward to us your questions via WhatsApp on 060 904 1056. Now, doctors. Dr. Nokia and Dr. Mathe, let's discuss diagnosis. How is glaucoma diagnosed?
So I think
Mambusa?
Dr. Nakia already alluded to that.
Mhm.
Essentially, we want to be able to demonstrate that or show that there is a change in the nerve, the way that the nerve of the eye looks, and there is a change in the way that the nerve of the eye works. So we'd have to look at the nerve. So it means a clinical examination by either an optometrist or an ophthalmologist. And then with that examination, we're looking at the nerve, and we're also assessing what the pressure of the eye is. Then we want to test whether the nerve works. And so we would do what we call a field test. So that just maps out what the field of the vision is. Because what you see when you get tested by your optometrist, when you're sitting in a chair, is not a full representation of what your vision is. So we do this as a special type of that maps out the vision of all the some points on the nerve that gives us an indication whether the changes that we see on the nerve correlate with what we are seeing in terms of the field change. And then we would do other tests that help us understand it a little bit better, especially when the disease is very early and it's hard to tell just by looking at the nerve. And this would be a test. It's sort of a scanning machine where we would then scan and take fine scans of the nerve of the eye, and we're able to appreciate if the nerve has been thinned. So you can imagine like the pressure causes thinning of the nerve over time. So we would want to look at a pattern that demonstrates that this process is happening, because we would see that there are parts of the nerve that are thin. And just to point out that not every patient has got a high pressure when they have glaucoma. And we don't always pick up that high pressure when they're being examined. So just the pressure alone might not give us an indication of disease, and it might not give us an indication that there is no disease as well. And then basically, those are essentially the main examinations that we do. I don't know if Dr. Nokia wants to add in anything there.
No, I agree entirely. It is a complicated disease, and in fact, there are many different types. And Dr. Mate has already alluded to the angle closure glaucoma, patients with acute glaucoma versus chronic glaucoma, and the subject can become quite complex. But for this program, it's better that we just keep it to the common, most frequently presenting form, which is the chronic open angle glaucoma, which the majority of our patients present with. But it is a complicated disease, and sometimes the diagnosis can be quite difficult to make.
Now, there's two questions that are coming from listeners. I'll pose the first one. Salam's good show and good topic. Does looking at the sun help for good vision?
No, it's not good to look at the sun because you can cause damage to your macula. It's unrelated to glaucoma, but you do not want to ever look into the sun because you can get what is known as a thermal and an ultraviolet damage to the photoreceptors, to the cones that are right in the center of your retina. So think of your retina as the film in a camera at the back of your eye, and you burn it with the light being too strong. So the simple answer is no. Never look directly into the sun.
Okay. There's a bit of a long question that's come through, so I'm going to go through it very slowly. I had an express valve inserted in my one eye 7 years ago. The operation itself was a success as my pressure is mostly 16 without anti-glaucoma eye drops checked with eye care tonometer. However, after the op, my conjunctiva was inflamed and had to use prednisone drops for a month. Since after the op, I have a discomfort in that eye, sometimes dry feeling, sometimes feel the valve, foreign foreign body feeling, sometimes like a wet feeling causing slight blur. I was told the eye doc is okay, is late. Okay, I have external ocular surface disease and prescribed eye lubricant to use and helps so. Is there anything more that I could do? Okay, it goes on to say, I'm on super Satan drops and my eye seems to be clear. Do I continue taking this if my vision is clear? And oh, sorry, there was a second question. My apologies. I've just mixed the questions. Let's just go on to the previous one.
So would say with what is described, the type of surgery, an express valve, is a small device, a small metal device that is placed in the eye, and the aim of it is to allow for the fluid in the eye to move out of the eye, and that fluid moves and sits under the skin of the eye. So that's the design of that implant, and that's how it helps to control the pressure. So what happens with some patients, that area where that fluid collects, which we call a bleb, is an area that we want to see because that's how we know that the surgery is working. Sometimes that area can be a little bit more lifted than what the eye likes. And so it can create a little bit of discomfort. It can also create patches of dryness in the eye because the way that the eyelid then moves over the eye and over that area of swelling is a little bit abnormal, and it doesn't move the normal tear film comfortably over that area. And so for a number of patients might experience that discomfort related to that and pain. And obviously the eye can dry up as well. And so if he's saying that the lubricants are helping, that's possibly what it is. If he's not on any other drops, because the other drops can also cause a little bit of irritation on the surface of the eye because they may have some preservative in them. So from what he's described, it sounds to me like that may be more along the lines of that related to that area of water coming out. We want that area. So we do try and manage it as best as we can conservatively. If his doctor says that area is really lifted, sometimes we can try and flatten that area a little bit so that it's not sitting and causing a little bit of a problem for the patient.
Thank you, Dr. Mate. The next
Faiz,
question
can
here.
I make a
Yes,
comment there quickly? I'd
yeah,
like
go
to
for it.
I'd like to congratulate that patient that sent in the question. That
Mm.
patient has a good insight into what's happening. That it was a very accurate description and very insightful patient, and has recorded and understood the situation very clearly. And I'm impressed with that patient, because I like my patients to know, understand what's happening, and participate in the management of the problem. And asking other people, getting second opinions, I personally am all for it. It sounds like that patient is well managed by that doctor, and I'd like to reassure that patient that it sounds like they're getting excellent care. Unfortunately, glaucoma is a difficult disease, and the complications they're describing do happen from time to time. It's beyond it's a part of the nature of the disease, unfortunately. And sometimes you have to learn to live with that. I always say to patients that red, burny, sore eyes that can see are much better than white, painless eyes that are blind.
Mhm. The next question is, if I'm on Spursatin drops and my eyes seem to be clear, do I continue taking this if my vision is clear and I've been diagnosed with glaucoma?
What drops? I didn't get the name.
Spersatan.
Spisatin,
Spursatin.
yes, that's a prostaglandin. And that is a prescription drug. The patient has been given the spisatin to control the pressure, and if that's what they've been prescribed by their doctor, they must continue it as per his instructions, his or her instructions. Yes.
Mm-hmm. Incidentally, the questions are pouring in. So the next question is, hi, if a patient has glaucoma, macular degeneration, and keratoconus, early onset of cataracts too, will their sensitivity to light be extremely high?
So
Yes. So
they have a number of, yeah. Please go ahead, Bill.
no, you go ahead, Jatumbo.
I was going to say that yes, very likely that they would, because they've got a number of different possibilities for causing light sensitivity. So the cataract, the keratoconus, they've mentioned the macular degeneration as well. So yes, it is definitely possible that they would have some degree of light sensitivity. Of course, if it's something that worsens, they should discuss it with their doctor so that they can exclude other possible conditions that may be flagging themselves to be beginning with that light sensitivity.
Okay, the next question comes. Okay, I've got like a minute for the ad break. I'll take the break and then I'll pose the question because it seems quite a lengthy question as well. We'll take the break. We'll continue on the other side of this. Do stay with us now. Hello. How's it, Jack? No, I'm not sharing anything on the break. It's totally dead. But everything is going very
Zero
well. I'm not,
207239.
now I'm hearing it. Now I'm hearing it.
Welcome to Simplex Radio. Visit our showroom for the full range of car audio. Our TV department carries top brands with quality LED panels, full HD to
Only thing
Ultra
I lost on
HD,
the
and
screen,
now the experience
all
of
the,
Super
the
Ultra
next to each
HD.
other.
Visit
Now
our
only when the
theater
top
rooms
comes.
and transform your home with brands like Onkyo, Integra, Denon, Boston Acoustics,
I somehow
Yamaha,
like the
and
picture
more
of
for
the
quality
then
audio
it's
visual
always looking at
experience.
one
Now
another when it's
available,
then
full
always
range
together.
of home appliances. A one-stop shopping
Thank you.
experience. Call 031 306 4029 or Kenilworth Park, 202 Brickville Road,
Sorry?
Overport.
Huh?
Simplex Radio, the name you can
Is it
trust.
that? Okay. Give me another hour on the show.
Africa Muslims
Just
Agency
keep on
has
sending
been
messages,
providing critical aid in Gaza and Lebanon with your support. The humanitarian situation is more dire than ever before, with thousands displaced and in need of basic supplies to survive. Donate any amount to bring food, water, medical assistance, and essentials to the people of Gaza and Lebanon. Africa Muslims Agency, empowering, educating, inspiring.
Hajj Seminar 2025 will take place on Saturday, the 12th of April at 207 West Road in Overport. Speakers include Qari Naeem Sheikh, Madrasa Aisha Siddiqa, Hafiz Ismail Kovadia, Sahuk, Head of Mission, Maulana Ahmed Muhammadi, Amir of Jamiyat al-Ulama KZN, Maulana Habib Milanzi from the Sunni African Ulama Council, Mufti Farooq Sufi from Habibia Sufi Sahib Masjid, Mufti Advocate Imran Vauda, Maulana Muhammad Vanka, Imam of Amshlanga Masjid, Maulana Junaid Kirsani, Mufti Ismail Basa, Director of the Al Burhan Institute, Mufti A.K. Hussain, Amir of Markaz Sahaba Radio, Maulana Ibrahim Muhammad from the Sunni Jamiyat al-Ulama. Rules and regulations for females during Hajj by Muallima Ansar Mia. Program director will be Hafiz Hussein Wadi. Program commences at 7:15 a.m. and will culminate at Zohar with a scrumptious lunch. That's Saturday, 12th April 2025 at 207 West Road. Proudly brought to you by the Al Ansar Foundation and the Capital Group of Companies.
The Al Ansar Foundation, Dawah, Tarbiyah, and Education, establishing the foundations of Islamic civilization in South Africa.
You're listening to Medical Files, brought to you by the Islamic Medical Association of South Africa and hosted by myself, Faisal M.J. Suleiman. Our topic for discussion is glaucoma, and our very special guests are Dr. Bill Nokia and Dr. Nombuzo Mathe, and both are specialist ophthalmologists. Doctors, our questions are pouring in. We still need to discuss treatment, but I'll pose one question to you before we go on to treatment, and then I'll come back to the questions. I'll come back to questions. The next question that comes is, Assalamu alaikum, doctor. I'm diagnosed with glaucoma. I'm on Ganfort eye drop plus ACS Comfort eye drops for dry tears. I have a very tiny cataract. I have lupus with 9 other autoimmune diseases. I'm on a lot of meds. Tell me, is chloroquine okay to take? I have blurry vision. I have tested glasses. Is there anything else that can help? And of course, I have a tiny cataract as well.
Shall I do it, Nombuzo? So
Please,
the patient is concerned about the chloroquine. And the chloroquine is used in South Africa for treatment of rheumatological disorders. And it theoretically can affect the retina. And so all the patients on chloroquine are seen on a regular basis. And we do examinations of the retina with a field test and a color vision test and a thing called an scan of the retina to look for side effects of chloroquine. Now, when I consider the number of people who are taking chloroquine, we see relatively few side effects. Unfortunately, there is a better drug called hydroxychloroquine, Plaquenil, which is available in Europe and North America, but is not available in South Africa, and it's purely for bureaucratic reasons that it's not available in South Africa, because it's a much safer drug. But by and large, it is, if the doctor, their rheumatologist feels they need to be on the chloroquine to control the rheumatology problems, and there are many rheumatological diseases that it's used for, it's generally safe for them to use it. Now, does it affect the cataract and the glaucoma? It does not, to my knowledge, affect the cataract and glaucoma. Sometimes you can get little hazy patches on the cornea called Hudson-Starley lines from the chloroquine, but it's not that common. And the management of the glaucoma with the Ganfort and the management of the cataract will continue as normal, whether the patient was on the chloroquine or not.
Thank you. Doctors, can we discuss treatment very quickly? We've got like 10 minutes and I've got tons of questions, but let's go to treatment. I think that's important, sir.
So there's different kinds of treatments available We would look at topical or drops medication, and that's what most people would probably start with. We do also now have access to laser technology that would also come in quite early in the treatment. So, of course, the ophthalmologist that makes the diagnosis will decide based on what the eye is looking like, what the nerve is looking like, how high the pressures are, how old the patient is, the status of both eyes, to decide what might be the best treatment. Most people will be started on drops. We do offer laser, and there are different kinds of laser treatments, but there's one specific one that we can offer quite early on, and it works very similar to what the drops effect would be. And then we do have different kinds of surgeries as well. Some surgeries we would call minimally invasive. So these are surgeries that we say they don't disrupt the tissue as much. And then there are those that are a little bit more invasive. And so once we get to the point where perhaps the drops are not working well, the laser hasn't worked, or the combination of these two haven't worked, we might then move over to surgeries. And within the surgeries, there's various kinds of surgeries. There's micro shunts, there's big shunts, there's creating a drain with the natural eye. So there are a number of different treatment options that we have available to patients. And these treatment options are available both in public sector as well as the private sector as well.
Thank you for that, Dr. Mathe. Dr. Nokia, do you want to add to that, or can I go on to the questions that are coming through?
Presenting here on the private chat, there's a lady who says, my mum has glaucoma. How does she check or monitor the pressure in the eye, often as when she only has it done when she has an appointment? And I often say to my patients, how often do you check your bank balance? And if you check your bank balance once or twice a year, most of us wouldn't survive. Yet, unfortunately, because of the nature of the disease, many glaucoma patients are only having their eye pressure checked once or twice a year, which is not always ideal. And so what I do to answer this lady is, as I alluded to earlier, our optometrists are really good in South Africa. And I often tell patients, every few months, pop into your local optometrist and speak to them. They have a machine. Most of them will have a machine that can check the pressure. And the optometrists in our country are very obliging and will often just do the patient's pressure. So many of my glaucoma patients will see me once or twice a year, but they'll see an optometrist once or twice a year as well to make sure. So in that way, they're having their pressure checked at least 3 or 4 times a year.
Another question that's come through is, how accurate is the eye care tonometer? Which is the best equipment to measure eye pressure?
So there's different schools of thought. There's a number of comparative studies as well. So they've compared the different types of technologies. As somebody who works primarily with glaucoma patients, I have my preferred choice, which is a Goldman tonometer. It is viewed as the gold standard for assessing pressures because it is less dependent or less affected by some of the anatomical differences that might happen in the eyes. And also, if the pressures are extremely high or a little bit on the low side, there's less variability. But essentially, I think for a patient, I don't think it's something that they should be too obsessed about, that I'm not getting my pressure checked with the gold standard. I think what's important is to be able to map out what the pressure is looking like. And any, ophthalmologist will be able to assess whether the condition in the eye, if there's anything that might impact the reading, and they may suggest another method. So there are different methods. There's the eye tonometer, there's the Goldman tonometer, there's different tonometers, the air puff tonometers. So there's a number of different alternative options. I think the consensus has been that they generally are quite similar, except in certain settings where the pressure is very high or the pressure is very low, where your eye tonometer maybe might not perform as well as your Goldman tonometer.
Thank you for that, Dr. Mathe. Salams, when my eyes clear, It gets blurry and itchy, especially when I read. I haven't seen a doctor as yet. Your advice, please.
This sounds like it's not a glaucoma patient, it's just a general question. Is that right?
It
Sounds like.
appears. Sorry.
So, what most people don't realize is that obviously we see with our eyes, but on the surface of our eye is a layer of tears. That layer of tears forms a clear film over the front of the eye, which allows the light to pass into your eye. And if your eye dries out, your vision becomes blurred. Your eye also becomes irritated because it acts as a lubricant between the eyelid and the eyeball each time you blink. And so any disruption to the tear film, what we often call dry eyes, which is really a tear film instability problem, leads to blurred or irritated vision, uncomfortable eyes, and particularly in Natal, because we're all in Natal, allergies is a common cause of that as well. So if you have allergies and certain what we call eyelid conditions, chronic meibomian gland dysfunction, it's where you get little inflammation of your lids. All of that leads to the symptoms that you've described. So it could be a number of things. So that person could start by going to either their GP or their optometrist and let them have a look at it. And if they feel it's more serious, they would refer you on to somebody like us, an ophthalmologist.
Mhm.
I might
Is
also
this?
add that,
Yes, yes.
if I can, that it also depends if he's reading, is he reading from a device? Because there's also, the effect of a device, whether it's a tablet or a phone, if you're spending time on that, it can also impact the way that light might impact the surface of the eye. And sometimes people that are really concentrating hard don't blink as frequently as they should. And that can, when the eye dries out, the brain sends signals to the eye to make more tears. So sometimes people don't understand when we say the eye is dry, but it's tearing, it's because that tear is not keeping the eye moist. And so the brain starts to send these signals to the eye to make more tears to try and compensate for that dryness. And so that might be what may be happening as well.
Okay. We've got like a minute to complete, but another question has come through. Good evening, excellent topic and show. What are the red flags for glaucoma? Can we deal with it in a minute or so?
No, Bussa.
So red flags, I would say young patient who is coming in with already quite marked changes in their vision in one eye. Somebody who has a family history, first degree family history, those are people I would worry about. Patients who are maybe have other systemic conditions, they may be using cortisone, they may have allergies as well, skin allergies, and they're using cortisone cream, and there's a buildup of this load of cortisone. And that can be especially patients that are older patients, very old, or very young patients who tend to be sensitive, and that can push them more towards glaucoma. Um, I think, I think that's, I don't know, Bill, if you want to add anything else in terms of just red flags. It's quite general.
Okay. Let's see. I've got questions are pouring in. I've got like 30 seconds to round up. There's another question that's come through. Can we deal with that very quickly? And is it related? Salams, I woke up this morning with a swollen eye more towards my inner top lids, closer to my nose bone. It's still sore now. Is that
Well, certainly that's unlikely to be related to glaucoma.
okay?
That patient almost certainly is having an infection of the meibomian gland, developing a small early sty. They can apply a hot compress to that, and if it gets sore or worse in the morning, they can pop along to their GP, who will prescribe them an antibiotic ointment. If it gets very big, we sometimes will anesthetize it and make a small little cut and let the pus out. It's quite common, what's just been described, and nothing to be overtly worried about.
Dr. Bill Nokia and Dr. Nambusa Mathia, thank you very much for joining me on the program this evening. And I must apologize to all the listeners for the questions that are pouring in. We don't have time to deal with them, but I want to thank you for having participated in the program and posed a question. Dr. Nokia and Dr. Mathia, I say thank you very much for joining me in the program and enjoy the rest of the evening. All the best to you, sir. And madam, thank you and all the best.
Thank you.
Thank you,
Thank you.
Mr. Suleiman. Thank you.
We spoke to Dr. Nokia and Dr. Nombusa Mathia, both ophthalmologists, and we discussed glaucoma. I want to thank the technicians in the various radio stations for having, the sterling piece of work that they've done and for have engineered the shows. Time for me to bid you farewell from myself, Faisal MJ Sulaiman. Till we meet again, it's Assalamu alaikum wa rahmatullahi wa barakatuh.